Okay, well, again, welcome everyone to our July Town Hall and our second part of our review of biostatistics. And again, we're glad to have Dr. Bolch with us, and I will go ahead and turn everything over to her, and we'll get started.
Perfect, thank you. Okay, can you see my screen?
Yes, we can. You're good to go.
Okay, perfect. Okay, welcome back, everybody. I am excited to kind of share with you the second part of the practicing pharmacist. And are you seeing the right screen? Are you seeing my notes?
No, we're seeing the presentation.
The presentation, okay, perfect, thank you. So I have no conflicts of interest. And then I just wanted to go over quick objectives. So the objectives of this talk are going to be to explain the purpose of hypothesis testing and why it's important. And then we're going to go through some that's kind of talking about what a p-value is. That's always something that's really kind of confusing to kind of anybody that's kind of learning statistics and has also learned statistics before and just kind of trying to understand what the difference between clinical and practical significance is. And then finally, we're going to go over some basic statistical tests, looking at different types of scenarios within a research study. So first off, we're going to go through kind of explaining what hypothesis testing is and p-values. So I wanted to bring back to this big picture of statistics, which I shared last time. So we're using data from a random sample to calculate summary statistics and also conduct inference about the population based on the sample. So last time we talked about kind of taking this random sample, having our data from that sample, and then kind of doing descriptive statistics in terms of our sample mean. And then the inference we talked about was confidence intervals. Well, this time we're going to focus, instead of our inference on confidence intervals, we're going to focus on hypothesis testing. So in hypothesis testing, we begin with a claim about the population. And we want to use the data that we have, that we've obtained from our sample, this random sample from the population, to provide evidence against this claim. And so what we're doing with our statistical hypothesis testing is we're assessing the evidence provided by the data against this null claim. And so the claim is assumed to be true of what's happening in the population unless there's enough evidence to kind of exist that we can reject that null claim. And so our hypotheses are based on these claims of what's going on in the population. So our hypothesis is, it's an educated guess. We usually translate the problem or whatever research question we're interested in into a form that can be tested with these two hypotheses. And so, for example, we might be interested in saying, is there a difference large enough to conclude the difference is real and holds true for the population parameters if we're looking at a difference between two groups? And so our hypothesis tests are framed formally in kind of two competing hypotheses. So we have the null hypothesis, and this is the claim that there's no effect or difference. So this is what we believe is going on in the population. And then an alternative is the claim for which we seek evidence. And so what we're trying to do with hypothesis testing is we take our sample data and we kind of see what's going on in this sample compared to the population. And what we usually want to see is that we have enough evidence to reject that there's no effect or difference and conclude that there is something going on in our sample. So an example of this might be that, and this comes from a study looking at black tea drinkers and coffee drinkers. And so these participants were randomized to drink 5 cups of either black tea or coffee every day for 2 weeks. And then after 2 weeks, they had a blood sample and was kind of checked to see if they were exposed to an antigen and the production of interferon gamma, which is like an immune system response. And that was measured after 2 weeks. And so our null hypothesis, for it to translate this kind of research scenario into our null and alternative hypotheses, our null hypothesis is that we believe that there's no difference between drinking tea and coffee. And so we are saying that the two means of this blood sample and measuring this immune system response are kind of not equal to each other. And so our alternative hypothesis is that we are seeing that drinking tea increases this gamma production more than drinking coffee. So we're thinking that for the tea drinkers, that they're going to have this higher level of immune system response. So why might tea drinkers have higher levels of this immune system response? Well, there's kind of two possible plausible explanations. So we can see that tea causes an increase in the gamma production of this immune response, or that if you were randomly assigned to tea, randomly assigned to the tea group, they have better immune systems than those who got randomly assigned to the coffee group, but it's just kind of random. And so in hypothesis testing, the goal is to determine whether random chance can be ruled out as a plausible explanation. And so what we're interested in seeing is how unlikely it would be to see a difference in means or proportions this large just by random chance. So once we've kind of set up our two hypotheses, we now can kind of go through these steps of testing to see whether we can reject our null and kind of conclude that we have enough evidence for our alternative. So we first set up our two claims, our null and alternative hypotheses, but what's going on in the population. And then we choose a sample and we collect the relevant data, and then we summarize that data. And then this brings into this idea of calculating our p-value. So step 3 is we're trying to figure out how likely is it to observe data like the sample we obtained if the first claim is true. So because we're trying to look at how likely it is, this is going to involve probability calculations, which is then comes into our calculation of the p-value. And then after we've kind of calculated and done our probability calculations, we make a decision in favor of the null or alternative hypothesis. So we either say the data provide enough evidence to reject the null and kind of go with the alternative, or the data do not provide enough evidence to reject the null. So we kind of have these two different kind of decisions we have to make after we do our hypothesis testing and calculate our p-value. So what is a p-value? So this kind of concept of a p-value can be kind of confusing, but we'll kind of go through kind of multiple different definitions and then also talk about statistical and practical significance. So a p-value it's just a probability calculation. So we're observing data that would be equal to or more extreme than what was observed if the null hypothesis is true. And so if our p-value is really small, this means that it's relatively unlikely that we would have seen this observed data if the null hypothesis is true. So we have our null hypothesis. We're usually saying that there's kind of no difference going on in the population. If our p-value is really small, so the probability of kind of observing that the kind of null hypothesis is true, if that's really small, then we assume that there's something going on in this sample. So there's something that's kind of involving either these two groups are something is going on with the means of two groups or more than two groups, or something's going on with the proportion. So that allows us to be able to say that we have enough evidence to reject this null hypothesis. And so what we're saying when we say chance is that it's not an unlikely explanation for what was observed. So chance in this context, we're talking about that random selection or random assignment. So it's not just due to the fact that these participants were randomly assigned to two groups. That's not the reason. There's something else that's going on in our sample. So when we draw conclusions based on the p-value, we compare a calculated p-value from our sample that we've conducted during our hypothesis testing to a cutoff. And so the cutoff is usually called the significance level of the test. Sometimes you kind of see it in the literature as alpha, and it's generally set to 0.05. This is just kind of the arbitrary number that statisticians long ago decided to set as the cutoff value, and it's kind of permeated through the last 30 or 40 years. So if our p-value is less than 0.05, the data is surprising if our null hypothesis is true. And so we can reject the null and kind of are in favor of this alternative of what we're kind of trying to seek evidence about. However, if the p-value is greater than 0.05, the data is not surprising enough when our null hypothesis is true. And so we don't necessarily accept the null. We want to make sure that we just don't have enough evidence to reject the null. And so a significance level of 0.05 is a good guideline that's kind of come up throughout the research for testing claims, but it shouldn't necessarily be treated as a hard and fast truth. So there's a lot of room for interpretation. If we get a p-value of 0.051, is that really different than 0.049? So we much rather prefer to see very small p-values where the conclusions are clear. And so most scientific journals usually consider a 0.05 to be the cutoff of any p-value. So any p-value equal to or above that does not signify sufficient evidence against the null hypothesis. However, there's been a big move in the kind of statistics movement to kind of get rid of p-values because it's been such a kind of hard and fast rule, which that wasn't ever the intent when they were kind of talking when statistical testing kind of came about with hypothesis testing. So in this kind of movement to get you away from just kind of interpreting the p-value, it's not that you're just trying to get rid of p-values entirely, it's that you want more information. So the move is to also include effect sizes, confidence intervals like we talked about last time, test statistics, and understanding that it's more important to kind of consider the context of what you're talking about with your null and alternative hypotheses rather than just the p-value. So we always want to make sure we draw our conclusions in the context of the problem. So it's never just enough to say the p-value is equal to this and therefore I reject. We always want to make sure we're having context of what we're actually doing with our hypothesis testing. So it's usually best to kind of write your conclusions in terms of the alternative hypothesis. And so you're saying, is there or is there not enough evidence that the alternative hypothesis is true? And we never say that we accept the null hypothesis. So usually the reason why maybe you're getting a p-value that's less than the significance level, there's a lot of different factors that are kind of playing into that. It could be sample size, you just don't have a large enough sample size to be able to determine significance, or something's going on with the study design. And so we never want to say that we accept the null and this is truly what's happening in the population. And so usually it's kind of common in journals. So you to kind of interpret the results as statistically significant and kind of providing the p-value. And then we also want to make sure that we're also including those kind of other values as well with our effect sizes and our confidence intervals as well. If you are reading literature and they're just kind of stating p-values and nothing else, it's kind of a warning that maybe you want to look a little bit more about what they're actually looking at, because the best practices are to kind of make sure you provide enough context of what's going on. So for statistical significance, just to kind of review, so if the results are significant, the results of our sample, what we're seeing in our sample, would be rare if the null is true. And so we have enough evidence against the null, and we have enough evidence that the alternative is true. So I just wanted to go over a few misconceptions about p-values. And so the first kind of misconception is that a hypothesis can show strong support for the null hypothesis. And so that's not true at all. So a large p-value just says that the data would not have been unusual if the null hypothesis was true. There's a difference between I'm convinced it's true and I'm not convinced it's false. So all the p-value is saying is that it would not have been unusual to kind of see what we're seeing in the sample kind of compared to what we're seeing in the population. Another misconception is that a p-value is about rejecting the null hypothesis proves that the alternative is hypothesis is true. So there's a difference between convincing evidence and proof. So we never want to say that we're really like proving that the alternative is true. We just have enough evidence based on our sample that we can conclude the alternative is true. And then finally, the p-value, one other misconception is the p-value is the probability that the null hypothesis is true. And so that's not true. The p-value just merely indicates the degree to which the data are incompatible with what is expected if the null hypothesis is true. So it's the p-value is the probability of observing data as incompatible with the null hypothesis, given that the null hypothesis is true, not the probability that the null hypothesis is true given the data. So there's a kind of a fine line in terms of how you're talking about the null hypothesis. And then finally, the kind of largest misconception that I see is that your statistical significance implies practical significance. And so this is not true. There's a difference between showing statistical significance just based on your hypothesis testing and then this idea of clinical significance or practical importance. So particularly with very large sample sizes, you may see statistical significance even for really small differences in kind of any value of a kind of mean difference or proportion difference between kind of two samples. And so what people kind of get in the weeds about sometimes is that you have 2,000 people that you're having in any kind of study, you randomize them to two different types of treatments, any kind of difference that you might see is probably going to be statistically significant since you have such a large sample size, but that might not necessarily be practically significant. So, and then also the p-value doesn't necessarily measure the size of the difference or the importance of a result. So the p-value is just telling you what's going on if we were able to sample again and again from the population with the same kind of study design that we have, would we expect to see this difference or not based on what we're looking at from the kind of population versus what we kind of seek to see in the alternative. And so, but you have to be able to kind of provide that what difference you're seeing and whether that's an important difference or not. And just because something, again, is statistically significant doesn't mean it's clinically relevant. So a lot of times I'm working with different types of researchers and they're proving like less than a 1% difference in some kind of value. I always like to bring it back to them. Is that going to be practically significant in what you're talking about? When you're kind of using a new drug to lower cholesterol or blood pressure, is that kind of one value difference? Is that significant? It might come up as statistically significant, but is that going to be clinically significant? And then we always want to make sure that we're kind of interpreting our results in context. So we never just want to say our p-value is less than 0.05, I have statistical significance, I'm done. So I also wanted to kind of bring into the fact the importance of effect size, since that's been something that's journals are wanting people to report more and more nowadays and not just p-values. So we want to really make sure that we're providing these effect sizes. They're either like standardized differences in means, or we're looking at different types of proportions. And so there's always going to be a point where a large enough sample size will result in not very clinically meaningful results, and they're going to be statistically significant. So that's important why providing that effect size allows you to see kind of what that clinical result is, and if that clinical result is important. Okay, so that's all about hypothesis testing and p-values. Now we're going to go into different types of statistical tests, and then I'm happy to take any kind of questions. I know it's a big kind of crash course and everything. So first off, with statistical tests, we first always want to make sure we go back and look at, okay, what's the research question that's happening? And what are our null and alternative hypotheses? What type of data was collected, and what was the study design? So these always really are important questions to ask when you're looking at kind of deciding what statistical test, or you're reading an article and trying to kind of understand why they used a certain type of statistical method. So when we're comparing two groups, we're usually interested in comparing like a quantitative variable across two groups. It might be, we want to see how do two means or proportions differ from one another. And there are kind of two situations for this. So the data can come paired or matched, or they can be from independent groups. And so in matched pairs, we have the same individual or patient or participant as a subject in both kind of treatment groups. So each observation is matched, paired, we sometimes call it linked, with an observation in the other group. So an example of this might be if, let's see, we're trying to compare two types of sunscreens. And so a participant applies sunscreen A to one arm and then sunscreen B to another arm. That would be kind of considered a matched or paired sample. So matching can be by person, you can have twins, or a pair of individuals who have been matched on similar characteristics. And then independent groups are just kind of two separate groups for comparison. So their independent samples are taken from each group. So an example of independent groups would be if you're conducting like a clinical trial, patients are usually randomized into two independent groups, those that are sometimes given a drug and those who are given a placebo. And each patient is only in one of those two groups. So I have kind of two different types of examples for these kind of statistical tests looking at two groups. So this first example, there was a pretty significant study in the Journal of American Medical Association about hormone replacement therapy in about 2002. And so before it was kind of commonly prescribed this HRT to postmenopausal women until the results of this large clinical trial were published. And so in this trial, about 8,500 women were randomized to take HRT, and then about 8,100 were randomized to take a placebo. And then they looked at whether these women developed invasive breast cancer. And so the kind of question that could be asked from this is, does hormone replacement therapy cause increased risk of breast cancer? And so what we're looking at is we have the proportion of women that were taking HRT who got invasive invasive breast cancer, and the proportion of women that were not taking HRT that were on the placebo who also got invasive breast cancer. Excuse me. Okay, so the null hypothesis would be that those two proportions are equal. And then the alternative, if we're going back to our question, is we're wanting to see if people that are taking this hormone replacement therapy, if their proportion is higher for getting invasive breast cancer. So we first are seeing that we're testing a difference in proportions. We can kind of answer this kind of cause and effect relationship because we're doing a randomized clinical trial with two independent groups. And so the appropriate test would be to do a two-sample proportion Z test. And so this is just comparing these two proportions between these two groups. And so a conclusion would be that we have statistically significant evidence that HRT increases the risk of invasive breast cancer. And so we're providing our test statistic, and then our p-value is less than 0.05. So when our p-value is less than 0.05, what we're doing is we have enough evidence to reject this null hypothesis, and we conclude the alternative. so that having hormone replacement therapy increases the risk of invasive breast cancer. So this is kind of another different example using two groups as well. So say that researchers are wanting to assess the effectiveness of a new drug in lowering cholesterol. They do a randomized clinical trial where patients are randomized to receive the new drug or placebo, and total cholesterol was measured after 6 weeks on the assigned treatment. And the question that we're trying to answer is there sufficiently strong evidence of a difference in mean cholesterol for patients on the new drug compared to patients receiving the placebo? So what we're doing is we're kind of going to be comparing the mean cholesterol values. So we have the mean cholesterol for the placebo group and the mean cholesterol for the new drug group. And our null hypothesis is that those two means between the mean cholesterol for those two groups are equal. And the alternative is that they're not equal, because we weren't necessarily with our question trying to see the mean cholesterol was higher for one group. We're just kind of trying to see if there's evidence that they're not equal to each other, that there's some kind of difference. And so with this type of setup, we're testing for a difference in means because we're looking at mean cholesterol. We have a randomized clinical trial, but with two independent groups. And we're going to be using a 2-sample t-test. So with means, we're going to be using a 2-sample t-test. As compared to with proportions, we use a z-test. And so a conclusion would be that the mean cholesterol is statistically significantly lower in patients on treatment with a new drug as compared to placebo. And then we're kind of stating the mean cholesterol for the placebo group with our standard deviation, and then the mean cholesterol for the drug group with our test statistic, and then our p-value is less than 0.05. So we've kind of gone through an example with two groups with proportions and means, but what if we have more than two groups? So more than two groups is usually fairly common in kind of research studies. And so what we're doing is we're taking multiple different samples from a population. And so we have different sample sizes with each of our groups, and we're trying to see not just if there's a statistically significant difference between two groups, say sample size from group 1 and 2, but we're trying to see if we have 5 groups, if there's a statistically significant difference between those groups. And so that specific test is an ANOVA test. And so an ANOVA stands for analysis of variance. And it's called the F test because it uses this specific type of distribution called the F distribution. And what we're really looking at with an ANOVA is we want to see this variation between our sample means over our variation within our groups. So what we're doing with an ANOVA is we're not necessarily looking specifically between two groups like we would with a t-test, but it's this kind of omnibus test. So we're looking overall, is there any kind of difference that's happening between our two groups? And then if there is, we then follow up with t-test to find out where the difference is. So an example of kind of an ANOVA that would be appropriate was kind of a journal article back in 1978 from the Lancet, and they looked at 22 bypass patients that were randomly divided into 3 treatment groups for different respiration, and then they looked at the folic acid in the patient's red blood cells that was measured 24 hours afterwards. And so what they were interested in the study was, does the amount of folic acid in red blood cells differ after 24 hours between the 3 treatment groups? So they just wanted to see, is there any kind of difference in the kind of folic acid within either of these 3 treatment groups? And so our null hypothesis is that we're seeing that there is the kind of mean value from this folic acid measurement is going to be equal among all those 3 groups. And then an alternative is that they're not going to be equal, that one of them, there's some kind of difference that's happening. And so with kind of ANOVAs, when we're looking at three groups, it's really common to kind of be looking at some kind of box plots. So here they have the red cell folate kind of measurement between these three groups. And this is kind of looking at that kind of distribution and spread. And then this is a similar graph, but it's looking at the means and kind of the error bars. And so from this analysis, they found that there is a statistically significant difference in mean folic acid in the red blood cells after 24 hours. And we have a p-value, it's less than 0.05. And so it's indicating that something's happening there. And so what needs to happen is that two sample t-tests are needed to kind of figure out where those group differences are. And so those can just be conducted as we talked about previously with the two sample t-test. You're looking at, is there a difference between group 1 versus 2, 1 versus 3, and then 2 versus 3. And as you can see, there is kind of no difference, which you can also kind of see from the graph as well. There's no difference between 1 and 3 or 2 and 3, but there is something going on between this 1 and 2 group. So the last kind of test we'll go over is the Chisquare test. And so with the Chisquare test, what we're looking at is we're not looking at any quantitative variables, we're looking at categorical variables. So our null hypothesis is that there's no relationship between two categorical variables. They're going to be independent. So there's nothing going on between these two variables, or our alternative is that there is some type of relationship between the two categorical variables and they're not independent. And so kind of setting up our hypotheses, we're using proportions because we're looking at categories. So we're seeing how many people have a specific category out of the whole. And so our null hypothesis is that the proportions are equal between those two groups. And then our alternative is that they're not equal to, there's some kind of difference happening. And so an example of this could be seen in a study where researchers were interested in testing the effectiveness of antidepressants. And so they randomly assigned participants to either receive these two types of medications and then a placebo, and they tracked whether they relapsed or not. And so for our null hypothesis, we're trying to see is there is kind of no relationship between relapse and the antidepressant. And the alternative is that there is something going on between the antidepressant chosen and whether or not the patient's relapsed or not. So from this study, kind of using the Chisquare test, we're able to reject the null hypothesis and conclude that there is evidence that relapse and the antidepressant are related. So we have our Chisquare test statistic of 10.5, and we have a p-value that's less than 0.05. And then with Chisquare tests, it's really important to also kind of provide percentages and kind of just saying that there is a relationship between these two variables is not as important as kind of saying what's going on. We found a relationship and now what is it? So for this study, they found that 83% of patients on the placebo relapsed, 75% of patients on lithium relapsed, and then 41.7% of patients on diazeprine relapsed. So that is kind of all I have, kind of a crash course and kind of reviewing hypothesis testing and p-values and then some basic statistical tests. So I'm happy to take any questions. And then I do have some about 4 post-test questions.
Any questions or comments? Okay, we'll go right into the post-test.
Okay. So the first question is, the process of hypothesis testing starts with the assumption that the null hypothesis is true, the null hypothesis is false, the alternative hypothesis is true, we don't know. whether the null hypothesis or alternative hypothesis is true.
Don't be shy, everyone. Come on.
I think it's A.
That's correct. Yep, good job, Sam. So the null hypothesis is true is what we're starting out with in our process of hypothesis testing. So remember that our hypothesis is based on these claims about what's going on in the population. And so we start with this assumption that the null hypothesis is true, that there's no difference or no effect that's happening in the population. And we're using the data from our sample to provide evidence against that claim. Okay, the next question is, which of the following statements about the p-value is true? So is the p-value the probability that the null is true, or the chance of getting an observed effect, the chance of getting observed effect or more when the alternative hypothesis is true, or a very small p-value allows us to say there's evidence to accept the null? Yep, it is B. Saba is saying B, and that's correct. Yep. So remember that the p-value just indicates the degree to which the data were incompatible with what is expected if the null hypothesis is true. So remember, we're saying that there's kind of no difference happening in the population. We take a sample, we calculate what's going on in our sample. And so this p-value is telling us if the chance of getting an observed effect or more extreme if there's no difference. And so if there is going to be some kind of difference, that p-value is going to be really, really small. And so we reject our null hypothesis and conclude what we're trying to seek evidence for, which is the alternative. Okay, so question 3. So what statistical method would be appropriate to answer the following question? So say you're interested in looking at hand washing and contracting COVID-19. So is hand washing associated with contracting COVID-19, which would be the appropriate statistical test? A 2-sample t-test for matched groups, a 1-way ANOVA, a Chisquare test of independence, or a 2-sample t-test for independent groups. So kind of a hint is to kind of look at what are we looking at? Are we looking at quantitative variables, or are we looking at categorical variables? So it's not A. It's not D. It is C. Good job, Emily. So for our chi-square test, remember we're looking at this relationship between 2 categorical variables. So they're hand washing or they're not, and they either have or they don't have the virus. So remember, that's a categorical variable. They're either in one category or they're in the other category. And we're wanting to see if there's a relationship or association. And so for A and D, those 2-sample t-tests, those are, remember, looking at a difference in means. So we have to have some kind of quantitative variable which we can calculate a mean value. And for the 1-way ANOVA, that's a similar type of process. We just have multiple groups. Okay, so the last one is kind of what statistical method would be appropriate if a researcher is interested in studying whether Americans gained weight on average while in quarantine by virtue of the pandemic. And so this researcher took a random sample of Americans and asked their weight before the pandemic and their weight kind of mid-2020 quarantine. So what type of statistical test would be appropriate for this? Two sample proportion z-test, a one-way ANOVA, Chisquare test, or two sample t-test for matched groups. Again, the first question is, what are we trying to look? Are we trying to look at a categorical or a quantitative variable? Yes, and then we're kind of looking at our study design. Are we trying to look at independent groups or dependent groups? And so see people saying B, and that is correct. So an appropriate test would be a two sample t-test for matched groups. So we're looking at a change in mean weight. And so our weights is going to be a quantitative variable, and we're looking at participants pre and post the pandemic. So they're their own matched pair. And so the same participant is used. So that's how we get those matched groups. Great job, everybody. So just some final take-home points. Statistical hypotheses are all about claims about the population, and we use inference based on data obtained from our sample to see whether or not we can provide evidence against this kind of claim. And again, a really important point is that statistical significance doesn't imply practical significance or clinical significance, and that when we're looking at kind of choosing an appropriate statistical method, we need to make sure we're kind of considering what are our hypotheses, what data is collected, categorical versus quantitative variables, and then what our study design is. We're looking at independent or kind of paired groups. And that is all. So thank you very much. It's been great seeing you 2 times, and please let me know if you have any questions.
Thank you again. Any final questions or comments? All right. Thank you very much, Dr. Bulch. Thank you again for being with us for 2 months in a row for the this review of biostatistics, and we appreciate you taking the time to help us out.
Charlotte, do you write for any of the BPS reviews?
Say that again?
Do you write for any of the BPS reviews or recertification programs?
No, I don't.
You don't?
No, I don't.
Well, good.
I'd be happy to help out. It's been really fun to kind of, I teach biostatistics, you know, for public health students, but it's been great.
We have something stewing in the state organization, so stay tuned. We'd love to
Okay, yeah,
be part of the
definitely.
group. So thank you.
Perfect. Yeah, you're welcome. Have a good evening, everybody. Thank you.
And so, all right, so we'll get back to the recording. And let me switch over my screen here. All right, so just remember, this is your time. So we're open this up for questions, comments as we go through, just some minor updates as always. With the COVID cases, we're still seeing a small rise. And of course, now we're shifting a lot of our attention to not only the Delta variant, but the new Lambda variant. And so we're seeing how that's going to be impacting as we go forward. I don't know if many of you saw, I think it was yesterday or the day before's report was the first time that we had 0 COVID related deaths in Illinois since March of last year. So I think that's a huge success for what we're starting to go through with the vaccination starting to take hold. And so with that number, we are above the 70% of states, 70% margin for the state for at least 1 dose. So we did meet President Biden's goal for July 4th. Unfortunately, the rest of the country did not. We've got 4 states that are lacking very much behind. And those states are significantly being impacted with cases. That should surprise absolutely no one on this call. But if you can see here, I'm glad the Department of Public Health is starting to split this into categories now. So we can see the adolescent population and our 18 plus, and then our seniors and 65 plus. So we're doing pretty well. We've got about 12.7 million doses have been administered, about 17,000 doses a day on average, and only got about 14.2, just 14.3 in inventory that have been completely administered or dispersed out to the state. So we're doing rather well. I still think any pharmacy needs to be engaging in with their patient base. And I like this gradient map a little bit better than what's on the state's website. You can see where there's a lot of opportunity still in the state for getting your vaccine. And Medicaid is going to be continuing to look at this. They are working with the federal government for an expanded, enhanced administration fee for going out to patients' homes. In the second phase of that, hopefully, we're hoping the pharmacists are going to be added to that. We've had discussions with HFS about that, so stay tuned for that. The state is needing help, and they've asked pharmacists to hopefully be able to help with getting into homes and helping with administering those that just can't get to a vaccination center. And this just came out just a little bit after 5 o'clock today. This is just reminding pharmacies that you have to reattest. And this is your annual reattestment that just says that you qualify for CAP funds. So this isn't just qualifying your normal quarterly attestation for your prescriptions. This is saying that your pharmacy meets the qualifications, and you have to do this every year. So please, we'll be sending this out tomorrow to members, but please help us by talking to your peer pharmacies that are in your locations that you encounter, and making sure that everyone does this. We're going to also be reaching out to other pharmacies to try to make sure we get more pharmacies in the CAP program. There are monies that are left on the table, and we know there are many pharmacies that are hurting and that do qualify that have not stepped forward. And we need to make sure that we're doing our best to get in touch with these pharmacies. So please help us to be able to reach out to these individuals. And that's really all I had for this evening. Wanted to keep it short because I know everybody's coming back from a holiday weekend, and it's trying to get refocused back in. And so I really appreciate those of you that were able to join us this evening. And of course, we recorded this for those that weren't able to. We know a lot of people are on vacations or are having birthdays. So, and I know frequent town hall attendee, past President Dennis Bryan, it's his 70th birthday today. So those of you who are friends with Dennis on social media, make sure to send him a comment. And I know Steve Clement, another past president, has a birthday this week too. So reach out to them as well. So with that, I will quickly turn it over to Starlin, because I believe she is going to be giving next month, her and Sabi, I think, are working on next month's topic. And so Starlin can quickly just give a quick preview of what their topic is.
So we were going to do a general overview. I can't really go through all billing for everything in 20 or 30 minutes. So can you in the chat, the people that are on here, besides that, I'll do like an overview of what is out there for us and what is the first topic you want to make sure I hit in billing. Is it I know Garth and I are working on some immunization that won't be ready by August, but I have overviews of MTM. And then of course I have lots of information on diabetes and diabetes prevention. But if there's something specific, if you could put it in the chat now. Or email Sabi or myself what you're interested in making sure that I bring up. I'll probably try to hit kind of what I do for the MTM class is go over some of the overviews and any of the changes we're waiting. There's 100 bills in Congress right now addressing telehealth and the extension of things after COVID. So right now till August 15th, we're still under the emergency. So we have those expanded services, but there's a broadband bill, which we support. And then there's several others, depending on where they tag them on there's over 100 that we're watching that expands that privilege. Even though the GAO and the MedPAC peoples do not think it's cost effective and came out against expansion of it. There are people that want a hybrid, and those of us who live in areas where sometimes transportation is an issue, especially at wintertime, even in the cities, and we have elderly people that may not want to get out in the traffic. So we're supporting the option of being able to have telephonic and telehealth virtual access to patients so they can do diabetes education, cardiovascular education, any kind of education, or you could conference them about a consult for your CMRs and things like that. One cool thing, I'd like to, Garth, did the governor sign our bill yet for House Bill 135?
No, not yet. He's slowly getting to the 600 bills that were sent to him.
Oh, he had 600?
Yeah.
So one of the things that I'm going to be presenting at ASHP summer meeting is talking about doing pharmacists providing oral contraception consultations via telehealth, because there's our new RX, NU RX, that's what they do. And so there's not any reason why after our bill gets signed and we get the rules and such that we couldn't do some of those consultations in the privacy of a person's private area, and then they wouldn't have to walk in until they pick up the prescription. So the birth control pharmacist group and and we've been kind of brainstorming, trying to put together a template based on delivering those services through telehealth. I think it'd be very popular in the 18 to 40-year-olds or 35-year-olds, whoever, in that population, especially if kids, I mean, speaking personally, my daughters had a hard time getting to a health professional when they went off to college because they had established one in their hometown and they didn't really have one on the college campuses that they went to. So if they would have had something like that, they would have jumped on it. So anyway, that's a service area that we could tap into for cash.
All right. Anyone else have any comments or questions before we wrap up for this evening?
Chronic care management billing. Oh, that's a long one.
But,
and you have to have a contract with the physician.
right. All right, everyone. We'll call it a wrap for this month, and we'll see everyone in August. Thank you.